And immunotherapies had a really big influence on outcomes for patients with metastatic non-small cell lung cancer, but there's still an incomplete understanding of which patients will and won't respond to these forms of treatment. And we make decisions based on biomarkers such as PD-L1 and potentially tumor mutational burden. But we know that there are patients who, for example, have a low PD-L1 test score but actually respond well to immunotherapy, and there's patients who have a lower tumor mutational burden, again, who respond well to immunotherapy. So, and again, patients on the converse who have high PD-L1s or high TMBs who respond poorly to immunotherapy. And what we hypothesize is that introducing measures of heterogeneity and clonality into these assessments of these biomarkers will help us better able to predict which patients will respond to immunotherapy, and also then help identify patients who might be appropriate for additional clinical studies of combination immunotherapies. You know, there's lots of novel therapies now for immunotherapy, and potentially could be used as a selection or stratification factor for those studies. And also then there's the whole plethora of experimental therapeutics, of cellular therapies, and whether those therapies should be targeted at clonal mutations that may mean that targeting those is more effective than targeting potentially subclonal mutations. And so we hope that all of this rich translational work, biomarker work, which has taken years of work by many people, will make a significant contribution to the management of patients with metastatic non-small cell lung cancer and hopefully improve patient outcome in the future.